Thank you, Dr. Alex. We have saved, thanks to Nagendra, strictly maintaining time. We will allow 2 questions for each of the authors. The first hand user. A mic to Dr. Kishore here.
If something occurs, the consumer law says that you have not given antibiotic, that's why this happened. So with this scenario, what to do? If you are not, even if you try to write gram positive, gram negative, which cover the antibiotic, both in eye drop and also oral tablet. So this is a problem from the public and problem from the consumer law. So what to do in these cases?
Sir, one, this is a defensive medicine. And in an era of 21st century, we need to get into evidence-based medicine. Second is, we have used this broad spectrum. This is inherent prescription practice that broadest you go, the best it is. So cover gram negative, cover gram positive. And that is where we have led to a problem. Because we have given ciprofloxacin and quinolone so much because of broad spectrum that carbapenem resistance is there, and it is close to 60–80%. Third, I think there are IPCs, IPC 77, IPC 80, IPC 82 protects us if we are adhering to good practices. We need to demonstrate that it was evidence-based. We need to demonstrate that there is an internal quality check. We need to demonstrate that it was evidence-based practice, and even law protects us. Most of the cases in the court is decided by expert witness. The judge doesn't have medicine degree, so he calls for an expert witness, and this IPC, these 3 IPCs basically protects us, and the expert witness also needs to know for I think global good. And then there are evidences which are there in the journals, which are there in the textbooks, which we need to comply with.
Yeah, question to Dr. Sanjeev. Hello, I'm Dr. O.P. Kansal, currently working on patient safety at national level. This antibiotic policy, it's a real good journey, and I've been following you that how tough it has been for you to undertake this. The challenge that I see is that the informal sector, you mentioned up to the level of Ayush doctors, that they are a hard nut to crack, or how do we regulate them? Even the informal sector, so to say quacks, whom we as doctors or as medical community officially don't want to recognize. But the hard fact is that they are also prescribing a lot of antibiotics, and without any rules and regulations. They don't even know the basics. How do we address, will the antibiotic policy be able to...
Is this a question or your personal comment?
No, sir, question.
It is too long a question.
Sir, the question is...
Please be brief.
Okay. The question is, how can this will there be any scope in antibiotic policy to cover this aspect? Number one. Number two, a suggestion. When you mentioned about states, I am ready to partner and contribute in any of the state policy formulations.
So we cannot keep debating that drugs are not of quality. The Ayush people are also giving it. We are basically saying doctors themselves don't know, and they are giving unwarranted. Let's start. Our issue is, let's not keep debating. Let's start. Let's start who has a formal training, that is basically doctors. Involve nursing staff and clinical pharmacists. And then we'll see, because if you take an ideal approach, that's not going to happen in the country because it's very diverse.
Yes. Sir, I am Dr. V.K. Goel from Delhi. We all are using rampantly the antibiotics, and above all the qualified people. Unqualified people, RMPs, and as you said, the chemists are dispensing the antibiotics. Why cannot we suggest the government to put the antibiotics in the narcotic category? Whenever anybody, we or unqualified or anyone, prescribe the antibiotic, he should keep the prescription. We will be also more vigilant, and that person unqualified will not be honored.
So there is a Gazette publication which already exists. 14 antibiotics and 14 anti-tubercular drug falls in this category. This was supposed to get implemented from 31st of March 2014. Unfortunately, there has not been much of work from the government to be able to adhere to it, but the Gazette publication definitely exists. My request is, don't wait for the government to act. Can you create a collaborative and work with this, with your professional bodies and for a larger good?
My question is to Dr. Lalu Joseph, and first I want to congratulate her on a commendable achievement in an institution like CMC Vellore. Ma'am, you said that understanding the intent of a standard is very important. We had experience in going for an accreditation in AHAP, that's a clinical research accreditation, where from the beginning they had given us a mentor who was working with us throughout the accreditation. Is it possible for NABH to provide a mentor right up in the front so we understand the intent? We don't call people to, outsource our job to others.
I'm asking Dr. Kalra to address that.
Actually, we only can recommend program on implementation. NABH carries regularly program on implementation for the particular standards. We can only advise that. Directly, we cannot provide any mentorship or any consultant for preparing the hospital for accreditation.
Dr. Kalra, if I may add, CAHO is doing mentoring. We have done it in Karnataka and with excellent results. In fact, yesterday or day before yesterday, the culmination of 2 government hospitals in Karnataka was a result of mentoring by assessors. It's not NABH per se, but NABH partners with CAHO, and CAHO now has a system for providing mentors. So you can get in touch with us and we'll help you with it.
What's happening is NABH being a semi-statutory body, they can't be done. Whereas CAHO is a group of people with quality as a mandate. You could draw support from those institutions.
Thank you.
Thank you. We've had an excellent session. To sum it up, I should thank Sanjeev for raising the awareness about the burden of bacterial disease, which is still a major threat, and the possibility of immunocompromised patients, oncology and dialysis patients, going to be hurt more severely in the days to come. He also emphasized and indicated the empirical use of antibiotic, and finally also the attitude of passing the buck. And finally he nailed out one feature: the ideal and the actual can never be together, but don't wait for them to get closer so that you lose precious time. The change should start with you and your team. Thank you, Sanjeev, for that. Your Kerala model can knock out many meropenem homes which spring up around every major hospital. I always call all my intensivists, within a year or two, a new house. I say, put a label, meropenem house. Lalu Joseph indicated the barriers and shared her quality journey as a mechanical engineer, her perception of threat walking into the area of healthcare, and the comfort after having realized, and the starting point is understanding the need and realizing that you can do it with yourself, with an effort, and you don't need hand-holding all the time. And she emphasized the need for teamwork, and it is a commitment of the entire body involved in healthcare delivery that can contribute to the success of any form of quality assurance or quality controls that can come in.
Just to emphasize, we have many administrators in this audience today. My humble request is, unless you go through the standard and understand it personally, you will never be able to appreciate when your team brings up the problem to you or request for a support. you will look at it more as a process or more as a commercial exercise more than understanding the intent. Personally, when NAB had started, probably I walked into Dr. Jani ji way back in 2007 and went through the auditor's exam myself. That's the only time that I realized what was necessary to support the team to achieve their things. The buck starts at the top, so if you are heading an institution and if your institution wants to go through the journey of NABH, please spend time and effort to understand the intent. Then your team will be that much stronger.
That is raising the level of commitment right from the top. And Alex, in his inimitable style, emphasized the need for effective communication for good healthcare delivery. He also indicated how effective communication is linked to the medical errors that one hears of quite often. And he also highlighted the fact that the time spent by a clinician with the patient and how critical it is. The awareness that in communicating in the healthcare sector, there is a diverse range of people with different capabilities to understand the communication, and therefore how everyone involved should enhance their skills to be an effective communicator across all people involved in the healthcare. To sum it up, you know, I always used to say, and just to add to what Thomas has said, please communicate. Communication is a must. It doesn't stop there. Documentation. Communication of the document that you have developed. Many a time documents remain as a document in the healthcare sector without the stakeholders not even being aware of them. And finally, whatever you communicate, whether it is to your team or to the patient, please document the communication. That is equally critical. Document, communicate your document, and document every communication you make. God bless us all.
Thank you. May I also request Dr. Nagendra Swami to hand over token of appreciation to Dr. S. Kunar for chairing the session.